A very warm welcome to this biomedical webinar titled Automated Control of FiO2 for the Newborn. And we're very happy to have you join us today. And we're honored to be joined by Dr. Tomasz Szczapa as our speaker for this webinar. Dr. Szczapa is an associate professor and head of the Department of Neonatology at Poznan University of Medical Sciences in Poland. Following the presentation, we will have some opportunity for some Q&A. So if you have any questions throughout the webinar, please feel free to pop them in the Q&A box and we will address these at the end for discussion. So without further ado, I would like to hand over to Dr. Szczapa. Thank you.
Thank you very much. Thanks for the invitation and the opportunity to discuss one of the relatively new modalities that can help us to optimize the care in the neonatal intensive care unit, and that is the automated control of oxygen supplementation. Let me share my screen and start with my slide presentation. Okay, so I hope that everyone can see my screen, and in case of any doubts, any technical problems as well, please use the chat option, so we will be able to sort this out. Yeah, so as Chloe said in her introduction, I'm coming from Poznan. That's a city in the western part of Poland, and I'm the head of the second department of neonatology. Amongst the modalities that we used, we also have some experience with the automated control of FiO2. At the end of my presentation, I will also share some of the findings from our recent study that were not published yet, but you will be able to learn about them, and hopefully this year a paper will be published. So as we all, as specialists involved in the neonatal care, know, oxygen supplementation is a crucial element of the neonatal intensive care. And however, oxygen should be considered as a very strong drug. It's a gas, but it's in the form of gas, but it's a drug. In many situations, it can help us to save our patients. However, we also know that as with other strong drugs, there are some significant side effects of the use of this drug, especially in the preterm population. So it is our aim as professionals that are looking after neonates to provide adequate oxygenation for the metabolic needs, but at the same time to avoid the extremes, so avoid hypoxemia and also avoid hyperoxia, as we know about their consequences. And what is still a challenge, we have some knowledge, but we're still not, we understand that we don't have the full understanding regarding the optimal target levels of oxygen, especially for the preterm infants. What we routinely use for monitoring in patients that require supplementation is the oxygenation monitoring using the non-invasive pulse oximetry and periodic controls of arterial blood gases. So pulse oximetry of monitoring, because it's non-invasive, it provides real-time data. We know that in the range that we are interested in most of the time, SpO2 levels have good correlation with the Ph.D. Levels. At the extremes, the correlation may not be very good, especially with the upper values. There are some additional tools that can be helpful. So some units are using near-infrared spectroscopy to get additional information regarding tissue oxygenation, and that can be a very helpful supplemental information as well. And as I said, with the severe values, with severe hyperoxemia and hypoxemia, the precision of the measurement of SpO2 may be limited. And what is also important from the both physiological and clinical point of view, there are several factors that can cause fluctuations of oxygenation in the population of preterm infants. We know that the control of breathing is immature, so that's why we see apneas in these patients. We see respiratory pauses. Airway obstruction may be a problem, even with subtle problems as head positioning. It may be periodic breathing. It may be a problem regarding low FRC due to the increased chest wall compliance and atelectasis in the preterm infants. Pulmonary hypertension may be additional problem. An additional problem can be also ventilator asynchrony, or in some extreme cases, ventilator malfunction or displacement of the interface can also influence these fluctuations of oxygenation. And of course, anemia is another important factor. As I mentioned before, the extremes are especially dangerous. Swings between these extreme values can also be dangerous for our preterm patients. We know that as with other systems, the antioxidant defense system is also immature in premature babies, so they may be more susceptible to the toxic effects of oxygen. And with hyperoxia, we are concerned about potential consequences such as bronchopulmonary dysplasia or retinopathy or prematurity. So these are some of the reasons for which we want to limit the values of oxygenation which are too high. However, with hypoxia, there is a risk of increased mortality and the risk of neurodevelopmental impairment. So we want to try to be somewhere in the so and as for today, we try to range between 90–94% of SpO2 measured with pulse oximetry. We know that even short-term exposure to oxygen can have toxic effects. It's one of the important papers from the group of Professor Maximo Vento, who has shown that when resuscitation with different fractions of inspired oxygen were used, it had significant impact on the parameters, on markers of oxidative stress, on inflammatory markers, but also on the risk of bronchopulmonary dysplasia. And this was just looking at the interventions and the supplementation of oxygen in the delivery room. So that's one of the examples how important this is. There were several studies, several trials comparing lower and higher targets for oxygenation. What we know today, as I said, there are still some knowledge gaps. With the lower oxygenations, there is a risk there's high risk of death and affected neurodevelopment, while with the higher values there's risk for ROP and BPD. So for that reasons, as I said before, for now this is the slide showing the fragment of the latest update of European Consensus Guidelines on the Management of Respiratory Distress Syndrome regarding oxygen supplementation. And as you can see, it's currently recommended that preterm babies that receive oxygen should be targeted in the range between 90 and 94%. To achieve that, we should set alarm limits in the adequate range, so at 89 and 95. And we should also remember about screening this group of patients for ROP, so that we can detect this early and intervene early. However, another issue is that even when we agreed on this range, it may be very difficult to maintain the targeted range in the real life, in the clinical practice. So here are just two examples of studies that were looking at this, and both groups here concluded that indeed it's really challenging to keep SpO2 values in preterm infants in the target range. Here is another example looking at the compliance in oxygen saturation targeting in preterm infants. And again, the authors have concluded that this compliance is slow in the preterm infants, especially in maintaining the SpO2 below the upper limits. There are several factors then that can affect this problem. For sure, education is crucial, so that we learn and we repeat the information regarding the consequences of the supplementation of oxygen and keeping our patients outside the targeted range, so that all the personnel understands why is it important to keep these values in the range. It's also important that we know how to use our monitoring devices, so that the personnel knows when the, for example, signal from the pulse oximeter is valid, to be able to assess the quality of the signal, to be able to interpret that in the context of the clinical condition of the patient. For sure, environment may play a role. Here we see an example of architecture of the unit, where it may make a difference whether it's a single patient room or an open space unit. For sure, the patient to nurse ratio plays a role, and we know that in many places around the world, including my country, we have significant problems regarding achieving adequate number of personnel in our units, and that for sure influences the quality of targeting. Then we may have some technical issues related to the equipment, so malfunction of the equipment, but also we need to know how to use the devices that we have available, to know some technical details regarding, for example, placement of the sensor, that all can play a role. For sure, human factors as well. So alarm fatigue it's a big problem. If there are too many alarms going off, then people will stop responding, or will have less response to these alarms. So we need to keep them in the adequate range. Consider using the function of delaying the alarms. So if the value goes outside the range, but for just a short period of time, we can set the device in a mode that will not go into the alarm straight away, but will give some seconds until it starts alarming. That can be helpful. Inappropriate limits are another factor. So as you can see, there are many elements that we should consider to optimize the process. So if we want to start some interventions to improve this difficult topic of SpO2 targeting, we should evaluate what are the local challenges, check if there is a local guideline or protocol, and if not, put it in place, and then monitor the compliance, looking at the trends, but also going around the unit and seeing how it works in the real life. So when we discuss how can we minimize oxygen toxicity in the NICU, then there are several interventions, as you can see, that we can consider. Some of them that I mentioned already. I think education is crucial, but especially in situations when you have problems with the adequate amount of staff, it would be number of staff, you would be looking for additional solutions. And one potential helpful tool could be the use of the closed loop automated oxygen control to improve the time spent in the range, and that is the topic of our meeting today. So the basic idea is quite simple. So in traditional setup, would have a pulse oximeter attached to our patient, and based on the readings, based on the alarms, we would come to the ventilator and change the setting of FiO2 on the blender until we reach the value which is in the range. When we use automated system, then the pulse oximetry module is connected, or usually is a part of the ventilator, and there is an inbuilt algorithm that would provide this intervention for us. So in other words, if the saturation goes below or above the targeted range, the setting of the FiO2 will be automatically changed by the algorithm. Here we can see a clinical example of a patient that had desaturations, and on the saturation is in the upper panel. On the lower panel, you can see the FiO2. So when this baby was desaturating, the nurse would increase the FiO2. When the SpO2 was going up above the range, then the FiO2 would be decreased. And again, with the saturation will be put back again. So you can see it on the chart. And on the panel on the right, on the B, you can see that this patient was switched to the automated mode. So you can even see that the shape of this tracing is different. Obviously, the automated system will have better response in terms of the time. How it works clinically is another issue, but you can even see that the shape of the tracing is different. So with the automated system, the adjustments are proportional to the severity and duration of the episodes of hypoxemia. There are different algorithms that are implemented in different devices. So there can be rule-based systems, proportional integral derivative systems, and adaptive systems. On the right, on the chart here, you can see an example that the modern systems will not simply just change the blender depending of the FiO2. Several additional conditions will have to be fulfilled. So the machine, for example, will check if the patient is on conventional ventilation, what are the tidal volumes, what is the percentage of leak, because we know that there are different factors that can influence desaturations. However, the machine is blind. The machine doesn't know, for example, if the patient has dislocated the tracheal tube. So, but some additional safeguards are already implemented in some of the systems. On the next slides, you will see a list of different studies looking at the effects of automated systems. These studies were looking at the time spent in the target range. There are quite many already. You can see that usually the numbers of included patients were not very big. Endpoints were slightly different between these studies, and also different systems were tested. But then when we look at the meta-analysis that were concluding and analyzing the effects of the studies were carried out already, and you can see that some of the early studies are 20 years old even. You can see the early studies of the automated control. And the conclusions of this meta-analysis are that the automated FiO2 adjustment systems indeed provide significant improvement of the time which is spent in the target range. So we know that they are effective regarding this aspect. Here is another more recent meta-analysis from 2022 with similar findings. Another challenge that I just wanted to briefly mention with some potential for the automated control. However, this is not available for the clinical use yet, but I wanted to share this idea. Is the idea of considering the use of automated systems in the delivery room, because we know that the optimization of oxygenation in the first minutes of life is very important. What you can see here in the middle of the slide is the reference range for saturations in the first minutes of life, and with the saturations here in this table after second, fifth, and 10 minutes. We know that especially for preterm infants, it's important that we reach adequate oxygenation, especially around the 5 minutes of life, fifth minute of life. So around 85% with the heart rate above 100. And we know it's important because if we are not able to reach this, then it can be a bad prognostic factor for these preterm infants. However, again, when we look how effective we are in the real life, it turns out that the majority of time in the early minutes of life is with the routine approach is spent outside the target range. So we can see here in the study, patients were below the prescribed targets for 28% of the time, and above those targets 37% of the time during the first 10 minutes. So we can see how difficult this is. And in this interesting study, this was an animal model study. It was tested whether it's possible to use an automated system. They used a ventilator with the Preco system and were comparing automated and manual control in a model of resuscitation. And the time you can see within the target range was slightly higher in the automated arm. However, this was not significant. There was a significant difference in the time spent above the target range. So it was significant. The proportion of time was significantly lower with the automated system as compared to the manual one. And last year, this was also tested in a relatively small group of preterm infants with very similar findings. So the time spent in the target range when manual control and automated control were compared was similar. However, the time spent above the 75th centile, this proportion was smaller in the automated group. Another interesting area is how this automated FiO2 control influences the tissue oxygenation. I mentioned NIRS measurement, near infrared spectroscopy measurements, which are used in some units. We are able to assess the tissue oxygenation. We are usually mainly interested in the oxygenation of the brain, but other tissues can also be monitored. A German group has been looking at the effects of automated systems on the cerebral oxygenation. However, they were not able to show a difference which would be statistically significant. Another study from 2020 compared not only brain oxygenation, but also splanchnic oxygenation with and without automated system. However, again, no significant difference was seen. This is unpublished data from a recent study from my center, a small study in which we were looking at the tissue oxygenation during the use of high flow therapy with automated FiO2. But the time spent in the target range was significantly, the proportion of time spent in the target range was significantly higher with the automated control, but that did not impact the tissue oxygenation as well. However, these patients did not have very severe respiratory failure. I believe that perhaps we might see more impact on the tissue oxygenation in the patients with more severe respiratory failure, but that's just my speculation. We don't have evidence for that. So we know that there are effects in terms of optimizing the time spent in the target range. There is good evidence for that. About the clinical implementation and the effects. So this is an example from the Netherlands when it was assessed how this works in the real life, and when the system was introduced, it was found that during oxygen therapy, preterm infants spend more time within the SpO2 target range, and they found significant reduction in hyperoxemia, but not hypoxemia. Did that influence clinical outcomes? That's another example. Unfortunately, not in this retrospective study. Not on the analyzed parameters. So one big unknown is how does the automated control influence the clinical outcomes? We still don't have that knowledge. However, there is a big multi-center study recruiting patients. And we're all waiting for the study to come up with the results so that we'll be able to assess whether this intervention impacts clinical outcomes. But that's still in the future. However, as a number of systems is available commercially, we know that there are centers that are using this method. Here is one of the examples from the UK, showing that there are some units that use it. They use it in different ways. Some units have written guidelines for the use. Some don't, which may have an impact on the efficacy as well. But at least we have some information that these systems are already used in the clinical practice. And this is data coming from Poland, data from a registry looking at different aspects of the use of automated FiO2 control. And you can see that the ratings of the systems are high. And the authors of this report concluded that this helps to keep the readings in the target range, reducing the exposure to SpO2 extremes. And it's not just doctors, but also nurses like it a lot. It allows them to focus on other interventions than the FiO2 titration. And what you can see here are the results of the TAROC study. It was a multi-center study that enrolled patients from 5 centers in the Netherlands and in Poland. We're looking at the effects of use of the PRECO system. 39 preterm infants were included in the final analysis, with the median gestational age of 27 weeks. There was the intervention in both arms lasted 24 hours, both for the automated and manual arm. There were no significant differences in the median FiO2, but when you just look at the rumor, there was a difference in this. There was a difference in the amount of the manual regulations. The median SpO2 was a bit higher in the manual group, around 94%. The time spent in the target range, one of the things that were especially interesting to us was significantly different between the groups, and the percent of time was significantly higher in the automated group. You can see 84 versus 43% of the time, with different amount of episodes below saturation, with saturation values below 80%. What you can see here is the histogram of the or the curve of the saturations. The gray line is the manual control, so you can see that the median value was higher, and the black line is the automated control. So we concluded that during the routine use, that was routine use of FiO2 and PRECO system in the variety of respiratory support modes, because these were not only non-invasive modes, but also invasive ventilation, the SpO2 control was enhanced as compared to manual control, with less needs for manual interventions. Are there any limitations? For sure there are. Some would argue that the automated control may mask clinical deteriorations, because when we see babies desaturate, it may be of clinical value to us. So it may be an early sign that something is happening with this baby. When the automated control is on, it may be more difficult to assess. However, observation of FiO2 trends then can be helpful. It may be more difficult to differentiate the hypoxemic events secondary to apneic episodes due to this masking, as I said. And there are also observations that with the automated oxygen, the devices tend to target middle range of SpO2, while in the manual control, there is a tendency to keep the SpO2 values in the upper range of the target. However, what is the clinical significance of this, we don't know. There are some technical problems. One of the issues that, for example, we had in my unit is that sometimes we would see differences in the SpO2 values between the values on the ventilator and on the main monitor, which can be difficult to interpret, and you know, we may feel uneasy which value you should follow. One of the problems may be that there are different technologies, FiO2 measurement technologies used, but we also saw it with the same technologies. So one reading can be in the target range, the other one outside the target range. For sure, you should make sure to troubleshoot, you should make sure that the sensor is properly placed, that it's working properly. Also check the settings, so make sure that the same settings you have on the main monitor in your NICU and also on the FiO2 settings on the ventilator, and also decide which monitor has got the priority. Very interesting topic is the potential influence on the workload and the cost effectiveness of the technology. One of the limitations may be the availability. So the cost of the equipment, you also need to use additional FiO2 sensor. The availability regarding the devices that have this option seems rising. There are more and more solutions on the market. Yeah, but we still need data regarding clinical benefits. Some of the screens from the ventilator that we use, that's the Fabian ventilator, the automated delivery screen on which you can start the preco on or off. Apart from setting the range, you can of FiO2, you can also set the range in which the system will work. So if it goes outside the range, you can have better control. So it won't allow putting, for example, the FiO2 to 100%. That it can be an additional safeguard. One important element, because on the screen you can see the plethysmographic curve, but on the left here you can see the quality of the signal. That can be helpful if you have some problems with the reading. So it will be an additional information, and if the signal is too low, the system will switch off. Some of the parameters that can have influence on how the system works. So something that I mentioned before, the averaging time, also the alarm delay that I mentioned in the introduction, monitored values that you can also see on the value with the not only signal quality, but you also have the perfusion index here on the screen. This is the log of problems that can be potentially recorded by the ventilator. So if there are some problems, you can check that retrospectively, and it's also helpful to look at the trends. Here you can see the trends of the FiO2 and the FiO2. A lot can be checked versus other parameters that are being monitored during the ventilatory support. Alarm strategy. It's a paper from Poland that was comparing different types of alarm strategy, and this group has found some benefits with the looser alarm strategy. So in summary, what we know for now is that the automated systems, they improve the time spent within the target range of saturation. And we know that these systems help to avoid the extreme values, hyperoxemia and hypoxemia. As for the future, for sure, we need the data regarding clinical outcomes. So we know how the algorithms work, but we're not sure about the clinical benefits. It would seem, well, we would expect that there is an effect, but if there is, we still lack the data. Another potential issue is to evaluate what is the optimal FiO2 target with the automated FiO2 control, because we are now using these targets that were assessed in studies that were using manual control. So this may not be the same. For sure, what would be helpful is the data regarding cost effectiveness and the influence of workload. I mentioned several times that there are different systems available with different algorithms, and they may have different efficacy. So for sure, we would need studies that compare these modes, different modes. And there's quite limited data regarding this, and also combined with different modes of respiratory support. So how these automated systems work with non-invasive ventilation, high flow therapy, or conventional ventilation. Something that that seems very exciting and that could be really helpful would be to have algorithms that support moving SPO targets, like in the delivery room stabilization. As I told you, there is already some data supporting this idea. It seems that it could be a big help in the delivery room if we could focus on, for example, keeping the face mask with the minimal leak around the face, or optimizing pressure in the patient, or other parameters. And the FiO2 could be automatically titrated based on the SpO2 readings. So for sure, this could be helpful. The role in the low resource and staff limited settings, that's another important topic. And one aspect that we cannot forget is the parental experience regarding the use of those automated modes. So I would conclude with that. Thank you very much for your attention, and I'm looking forward to questions. Thank you very much.
That's great. Thank you so much, Dr. Szczapa, for your fantastic presentation. The first question we have is, what are some of the challenges that you may face as a new neonatal unit that's implementing an automated controlled FiO2 system for the first time?
Okay, so first of all, it's a kind of new approach. It's a new idea, so you need some time to start trusting these systems. It may take a while. You need to learn how the machine works. One of the obstacles that I can repeat this, I mentioned it during my presentation, is to make sure that your two systems for SpO2 control are working in accordance, so to say, because some of the problems that we encountered in my center is that we had a baby with two pulse oximeter probes. One was attached to the main monitor, the second one was attached to the ventilator, and sometimes we had these situations that, according to the SpO2 module in the ventilator, the patient was in the target range, but the main monitor was alarming because it was outside the range. And this can be quite frustrating for the team. And you need to troubleshoot this, because otherwise people will be uneasy, and this may be stressful, and they may not want to use this kind of system. The way we solved that was that, well, first of all, you need to make sure that it's a similar technology. But even with similar to the same technology, like in our case, we sometimes encounter this problem. What may help to make sure that the settings of the pulse oximetry model are the same. Like one of the examples is the averaging time. You should make sure that it's also the same type of the sensor that you are using. We even updated the software in our main monitors in the NICU, in the central monitoring system, and that helped a lot. Which of these interventions is difficult to say, because it was done at the same time. Yeah, but there are some ways to go around it. However, it's tricky indeed that you may have same technology, same sensors, and still see different values. So if these situations happen from time to time, then what can be helpful to agree on which of the values has got the priority. If you consider one monitor or the other monitor as a priority, that can also be helpful so that people are not completely confused. So that can help a lot. But I think this thing that I mentioned regarding the trust is important. So if it works well in the early phase, then especially nurses, midwives, they can benefit from it, and when they see that this works, then they can focus their attention on other aspects of the care. And of course, it's also important that you know your device, because there are some subtle differences regarding the settings between the devices. So you need some time for the introduction of the system in your unit.
Thank you. And are there any patients that you would choose not to use automated control of FiO2 for, or would you be able to use it on every patient in the NICU?
You would be able to use this on every patient. However, if you have a baby, for example, that is stable on low settings of, let's say, high flow therapy on room air, and the saturations are stable, then in these patients we would not use it routinely, because that again depends on, for example, how much you have to care about the budget, right? It is important in my setting. So if we do not have to use an additional sensor, then we don't do it. And it's also the question of the comfort of the patient. Why place another sensor if there is no or very little potential benefit from that? So, but then there are other groups which can benefit a lot, like for example, patients with severe bronchopulmonary dysplasia that are very labeled, that you can see that their saturations are going up or down, up and down. That in these patients, this is really helpful.
Thank you. And we have one question. Is there any experience in congenital heart disease, especially those with a large shunt?
That's a good question. I mean, I don't know any data from pediatric cardiology units, but you can use it in a cardiac congenital heart defect as well. Just make sure that the target range that you use is in accordance of what the pediatric cardiologists would expect for this kind of congenital heart defect. So we know that in these situations, we might not want to have saturations which are too high, but you can also set it on the device. However, to be frank, I don't know studies that would be investigating the use of automated FiO2 in patients with cardiac defects, and my experience is limited. So if you want, it's technically possible to use it, but if there are significant benefits, I think that we don't know, or at least I don't know about it.
Thank you. Another question is, are you planning to correlate pulse oximetry saturations with NIRS in the future?
Well, yeah, you could look for correlation. It's important that to remember that these values are from the physiologic point of view, these are different things, because when we are talking about saturation, that's the information of let's say more or less how much oxygen is delivered to the organs, to the tissues. And when we look at NIRS signal, we get the information about the local, the regional saturation, and correlation may be one thing, but what can be what could be even more helpful is to using these two values, you could get the information regarding the oxygen extraction in the over the tissue that you are monitoring. If you have these two variables, so you could calculate the FiO2. And I know one device that is capable of showing that. So both signals go into one device, and then you would have information about the SpO2, STO2, which is the tissue oxygenation, and then you can also have the calculated value of the fractional tissue oxygen extraction. So this can be helpful, and I think it's the future that we actually look for automated support of analysis of also these signals that we monitor, such as SpO2, tissue oxygenation, and perhaps other parameters as well.
Thank you. And how did the nurses on your unit react to the implementation of using the automated control of FiO2 systems? How long did it take them to feel familiar and comfortable in using it as part of their daily practice?
Initially, they were open, but they were not sure how much they can trust the device. The difficult period was the time when we had this problem with different readings on the screen of the ventilator and on the monitor. But I think it's really important that during that time we did not give up on this. So we were able to solve this problem, and now we all know that if it happens it happens sometimes still for short periods of time, then it doesn't mean that you have to switch off the automated system. It's like these systems are not perfect, but still there are benefits of the use of it. I think good cooperation and also discussions with the nursing team, how the system works, what's the idea, what are the potential benefits, that helps a lot. And then initially they may have limited trust, but when they see that it works, I think most nurses would really like the system.
That's great, thank you. And another question's come through. Do we need to use a special monitor? What do we need to have in our unit in order to use the system?
Okay, so if you want to use the automated controller, you actually need to get a ventilator that has got this option inbuilt to make sure that this is safe. And with the systems that are currently available, that's how it works. So the SpO2 module is built inside the ventilator. There is a window that you can access to look at these values and turn this on and off. So you could also place the sensor first on the patient, look at the quality of the signal, look at the values on your screen, because SpO2 will be shown on the screen, and then you can just switch the system on or off. So you don't need any, let's say, additional piece of equipment to use it. It's in most of the cases it's just a module which is inside the ventilator. So you just need to make sure that you have a model which has got this option built in. The additional thing that you have to use is an additional sensor. So perhaps in the future it might be possible that we have one pulse oximetry sensor that is sending signals to the main monitor and to the ventilator. That would make sense, but for now you need an additional sensor. So one sensor goes to the main monitor, and a separate sensor is connected to the ventilator to make sure that the system works.
Great, thank you. And another question is it the same for non-invasive as it is for invasive or high flow using the systems?
Yeah, exactly. You said it the same way. and it seems to work well in animals, but I would expect most benefits in those patients with most severe respiratory failure, but that's my speculation.
Thank you. And that's all the questions that have come through. So I want to say a huge thank you so much for your wonderful presentation. We're so grateful for your time. And
Thank you very much.
all of our attendees as well. And I wish you a great rest of your day.
Thank you very much. Same to you.
Thank you.
Bye-bye.